You might have heard about this bronchial asthma. So bronchial asthma treatment ಬಗ್ಗೆ ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡೋಣ. Very common clinical condition. So what are the drugs? What is the pathophysiological changes in bronchial asthma? So ಅದರಿಂದ ನಾವು ಹೆಂಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಡಿರೈವ್ ಮಾಡ್ಬೋದು ಅಂತ ನೋಡೋಣ. ಆಮೇಲೆ clinically, as I said, very important. Next, with respect to your exam, one of the favorite topics ಏನಂದ್ರೆ what are the drugs used in the treatment of bronchial asthma ಅಂತ ಕೇಳಬಹುದು, inhalational drugs used in the treatment of asthma ಅಂತ ಕೇಳಬಹುದು, inhalational corticosteroids ಅಂತ ಕೇಳಬಹುದು, ಅಥವಾ mentioned drugs used in the treatment of status asthmaticus ಅಂತ ಕೇಳಬಹುದು. So again, very important topic, both clinically as well as with respect to your exam. So we'll discuss about bronchial asthma. So first thing is, so what we'll do is we'll try to understand the pathophysiology. So pathophysiology understand ಮಾಡ್ಕೊಂಡ್ರೆ you can guess the group of drugs. So there is no need of memorizing the drugs. Classified drugs used in the bronchial asthma ante enadru bandre, if you see the textbook, there are many categories of drugs. So then you first ge memorize madak hogi adan complicate madokinta, it's very easy, is one of the easiest method is to understand the pathophysiology. Yen agakate anta ನೀವು understand ಮಾಡ್ಕೊಂಡ್ರೆ you can guess the group of drugs. Drugs you have to remember, yes, but at least you can guess the group of drugs. It becomes more easy for you to understand or to remember the drugs if you start like this. So simple, respiratory system olage, if you take respiratory system, okay, lungs. So idu now maximum zoom madonilla, there is alveoli, bronchus ಅವೆಲ್ಲ ಇರ್ತಾವೆ ಇಲ್ಲೇ. So if you take this bronchus again, ಇಲ್ಲಿ ನಾವು highlight ಮಾಡಿದ್ರೆ, okay. So ಬಾಡಿಗೆ one mechanism you already know. ಯಾವುದೇ ಫಾರಿನ್ ಆಬ್ಜೆಕ್ಟ್ ನಮ್ಮ ಬಾಡಿಗೆ ಬಂದ್ರೆ ಬಾಡಿ ಹ್ಯಾಸ್ ಇಟ್ಸ್ ಡ್ಯೂಟಿ. ಸೊ ಬಾಡಿ ಡ್ಯೂಟಿ ಏನು, ಅದನ್ನ ಹೊರಗೆ ಹಾಕ್ಬೇಕು ಹೆಂಗಾದ್ರೂ ಮಾಡಿ, ಬಿಕಾಸ್ ಇಟ್ ಡಸಂಟ್ ಬಿಲಾಂಗ್ ಟು ಅವರ್ ಬಾಡಿ. ಓಕೆ, ಸೊ ದಟ್ ಈಸ್, and the body follows this very promptly, and that is the reason why we remain healthy, because ಯಾವುದೇ ಫಾರಿನ್ ಆಬ್ಜೆಕ್ಟ್ ಬಂದ್ರೆ it blindly follows its duty. What is that? ಫಾರಿನ್ ಆಬ್ಜೆಕ್ಟ್ ಬಂತು or antigen ಬಂತು, antibodies ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡೋಕೆ ನಾವು how body ensures this. ಸೊ ಅದನ್ನ ಇನ್ಎಫೆಕ್ಟಿವ್ ಮಾಡ್ಬೋದು, ಅಥವಾ ಅದನ್ನ ಕಾಲ್ ವಾಟ್ ಎವರ್ ಲೈಸಿಸ್ ಮಾಡ್ಬೋದು, ಅಥವಾ ಹೊರ ಹಾಕ್ಬೋದು ಏನಾದ್ರು. ಸೊ ಇಟ್ ಸ್ಟಾರ್ಟ್ಸ್ ಇನ್ಫ್ಲಮೇಟರಿ ಪ್ರೊಸೆಸ್. ಹೌ ಇಸ್ ಇಟ್ ಅಚೀವ್? ಇಮ್ಯುನಿಟಿ ಸ್ಟಾರ್ಟ್ ಮಾಡುತ್ತೆ, ಇನ್ಫ್ಲಮೇಟರಿ ಪ್ರೊಸೆಸ್ ಸ್ಟಾರ್ಟ್ ಮಾಡುತ್ತೆ. ಸೊ ಇನ್ಫ್ಲಮೇಟರಿ ಸೆಲ್ಸ್ ಬರ್ತಾವೆ, ನ್ಯೂಟ್ರೋಫಿಲ್ ಬರ್ತಾವೆ, ಅದೆಲ್ಲ ಬರ್ತವೆ, ನ್ಯೂಟ್ರೋಫಿಲ್ ಸೆಲ್ಸ್ ಬರ್ತಾವೆ, ಆಮೇಲೆ ಲಿಂಫೋಸೈಟ್ಸ್ ಅವೆಲ್ಲ ಬರ್ತಾವೆ, ಇನ್ಫ್ಲಮೇಟರಿ ಮೀಡಿಯೇಟರ್ಸ್ ಬರ್ತಾವೆ. ನಾವು ದೇ ಆರ್ ನಾಟ್ dangerous to the body in physiological conditions. They have specific function, but in some conditions they become more marked. So that's why we have this concept that they are very dangerous, but normally they play very important role in defense of the body. Okay, so yade foreign object bandra, there is inflammatory process by which the body will ensure that the individual is healthy. So immunity attack start ಮಾಡುತ್ತಾ, ಅದನ್ನ ಲೈಸ್ ಮಾಡುತ್ತೆ, ಮೈಕ್ರೋ ಆರ್ಗಾನಿಸಮ್ ಅದನ್ನ ಸಾಯಿಸುತ್ತಾ, ಬಾಡಿ there is no chance of infection. ಸೊ ಯಾವುದೇ ಹೊರಗೆ ಬಂದ್ರು, ಇವನ್ ಅಟ್ ಇದು ಮಾಲಿಕ್ಯುಲರ್ ಲೆವೆಲ್ ಆಯಿತು. ಸೇ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ನೀವು ಡಸ್ಟ್ನೇ ಇನ್ಹೇಲ್ ಮಾಡಿದ್ರು, ದ ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್ ವಿಲ್ ನಾಟ್ ಅಲೋ ಟು ಗೋ ಇಟ್ ಇನ್ಸೈಡ್. ಸೊ ಕಫ್ ರಿಫ್ಲೆಕ್ಸ್ ಇಟ್ ಸೆಲ್ಫ್ ಇಸ್ ಅ ಡಿಫೆನ್ಸಿವ್ ಮೆಕ್ಯಾನಿಸಮ್. ಸೊ ಕಫ್ ಬಂದದನ್ನ ವಿ ಟ್ರೈ ಟು ಎಕ್ಸ್ಪೆಲ್ ಇಟ್ ಔಟ್. ಓಕೆ, ಸೊ ಮೂಗೊಳಗೋದ್ರೆ ವಿ ಟ್ರೈ ಟು ಸ್ನೀಸ್ ಇಟ್, ದ ಬಾಡಿ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಇನ್ಕ್ರೀಸಿಂಗ್ ದ ಸಿಕ್ರಿಷನ್. ಸೊ ಸಿಕ್ರಿಷನ್ ಮುಖಾಂತರ ಅಥವಾ ಸ್ನೀಸಿಂಗ್ ಮುಖಾಂತರ ಇಟ್ ವಿಲ್ ಸಿಗ್ನಲ್ ಯು ಟು ಎಕ್ಸ್ಪೆಲ್ ಇಟ್ ಔಟ್. ಓಕೆ, ಸೊ ದಿಸ್ ಇಸ್ ನಾರ್ಮಲ್ ಬಾಡಿ ರಿಯಾಕ್ಷನ್. ಬಟ್ what happens in asthma? Say for example dust. So ನೀವು ಡಸ್ಟ್ ಎಕ್ಸ್ಪೋಸ್ ಆದ್ರೆ ಏನಾಗುತ್ತೆ, you will have allergic reaction. Okay, you will have allergic reaction, sneezing ಇರುತ್ತೆ, maybe cough. Okay, ಆದ್ರೆ that is normal. So the dust exposure ಕಿಂತ ಸ್ವಲ್ಪ ದೂರ ಹೋದ್ರೆ it will stop, or for some minute it will be there and then it will stop by itself. That is normal response. ಅಸ್ತಮಾದೊಳಗೆ ಏನಾಗುತ್ತೆ, there is hyper responsiveness or hyper inflammation. ಸೊ ನಾರ್ಮಲ್ ಕಿಂತ ಮೆನಿ ಫೋಲ್ಡ್ ಟೈಮ್ಸ್ ಬಾಡಿ ರಿಯಾಕ್ಟ್ ಮಾಡುತ್ತೆ, ಹೈಪರ್ ರಿಯಾಕ್ಷನ್ ಮಾಡುತ್ತೆ ಬಾಡಿ. ಓಕೆ, ಸೊ ಹೈಪರ್ ರಿಯಾಕ್ಷನ್ ಹೆಂಗ್ ಮಾಡುತ್ತೆ? ಸೊ ನಿಮ್ಗೆ ಏನಾದರೂ ಬಂತಂದ್ರೆ ಸರ್ ಕಫ್ ರಿಫ್ಲೆಕ್ಸ್ ಆಗೋದನ್ನ ಕಾಂಟ್ರಾಕ್ಟ್ ಮಾಡಿ ಹೊರಗೆ ಹೋಗುತ್ತೆ. ಸೊ ಹಿಯರ್ ಏನಾಗುತ್ತೆ, ಬ್ರಾಂಕಿಯಲ್ ಮಸ್ಕ್ಯುಲೇಚರ್ ವಿಲ್ ಕಾಂಟ್ರಾಕ್ಟ್. ಸೊ ಬಿಕಾಸ್ ಆಸ್ ಎ ಕಾಂಪೋನೆಂಟ್ ಆಫ್ ಇಟ್ಸ್ ಇನ್ಫ್ಲಮೇಟರಿ ರಿಯಾಕ್ಷನ್, ಮೆನಿ ಇನ್ಫ್ಲಮೇಟರಿ ಮೀಡಿಯೇಟರ್ಸ್ ಬಂದ್ಬಿಡ್ತಾವೆ. ಓಕೆ, ಹಿಸ್ಟಾಮಿನ್, ಇಂಟರ್ಲ್ಯೂಕಿನ್ಸ್, ಸೊ ಇವೆಲ್ಲ ಬಂದು ಅಲ್ಲೇ ಅಕ್ಯುಮುಲೇಟ್ ಆಗ್ತಾವ. ಅಕ್ಯುಮುಲೇಟ್ ಆಗಿ ಏನೇನು ಕಾಂಪೋನೆಂಟ್ಸ್ ಆಫ್ ಇನ್ಫ್ಲಮೇಷನ್ ಅಂದ್ರೆ ಫಸ್ಟ್ ಅಂಡ್ ಫಾರ್ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಈಸ್ ದೇರ್ ಇಸ್ ಕನ್ಸ್ಟ್ರಿಕ್ಷನ್, ಬ್ರಾಂಕಿಯಲ್ ಕನ್ಸ್ಟ್ರಿಕ್ಷನ್. ಬ್ರಾಂಕಸ್ ಇಷ್ಟು ಓಪನ್ ಇದು ಏರ್ ಫ್ಲಾಕ್ ಇದ್ದು ಇಟ್ ವಿಲ್ ಕನ್ಸ್ಟ್ರಿಕ್ಟ್. ಸೊ ಏನಾಗುತ್ತೆ ಕನ್ಸ್ಟ್ರಿಕ್ಟ್ ಆದ್ರೆ ಏರ್ ಬರೋದು ಹೋಗೋದು ಸ್ಟಾಪ್ ಆಗುತ್ತೆ. ಓಕೆ, ದಟ್ಸ್ ವೈ ದ ಪೇಷಂಟ್ ವಿಲ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಡಿಫಿಕಲ್ಟ್ ಇನ್ ಬ್ರೀದಿಂಗ್. ಇನ್ಫ್ಲಮೇಟರಿ ಮೀಡಿಯೇಟರ್ಸ್ ಬರ್ತಾವೆ. ದೇರ್ ಇಸ್ ಇನ್ಕ್ರೀಸ್ ಪರ್ಮಿಯಬಿಲಿಟಿ ಇನ್ ದ ಸೆಲ್, ಸೊ ಫ್ಲೂಯಿಡ್ ಕಲೆಕ್ಷನ್ ಆಗುತ್ತೆ. ದೇರ್ ಇಸ್ ಕಲೆಕ್ಷನ್ ಆಫ್ ಮ್ಯೂಕಸ್, ದೇರ್ ಇಸ್ ಕಲೆಕ್ಷನ್ ಆಫ್ ಡಿಫ್ರೆಂಟ್ ಟೈಪ್ಸ್ ಆಫ್ ಲಿಕ್ವಿಡ್ ಬರೋದ್ರಿಂದ ಏನಾಗುತ್ತೆ, ದೇರ್ ಇಸ್ ವೀಸಿಂಗ್. ಓಕೆ, ಸೊ ಫ್ಲೂಯಿಡ್ ಅಕ್ಯುಮುಲೇಟ್ ಆಗುತ್ತಾ. ಸೊ ದೇರ್ ಇಸ್ change in the lung tissue, architecture of the lung will be changed, so that is known as the remodeling of the lung. So it is hyper responsiveness. So we'll see hyper secretion of mucus because there is airway inflammation. It is increased by many folds. Okay, airway muscle contraction, swelling of bronchial membranes. So all this will cause ಏನಾಯ್ತು. So ಇದೆಲ್ಲ first of all there is constriction, there is accumulation of fluid. So air ಬರೋದು ಹೋಗೋದು ಇಲ್ಲಿ ಬರೋದೆಲ್ಲ ಕಡಿಮೆ ಆಯ್ತು because there is constriction. Okay, so all this will cause narrowing of the breathing passage. So ಯಾವ ಮುಖಾಂತರ ಏರ್ ಒಳಗೆ ಹೋಗ್ತಿತ್ತು ಕಡಿಮೆ ಆಯ್ತು ಡಯಾಮೀಟರ್, ಅಲ್ಲದೆ ಒಳಗೆ ಹೋದ ತಕ್ಷಣ there is inflammation which is going on. So this is what is happening. Okay, so this will cause wheezing, cough, shortness of breath and tightness in chest. Okay, so secondary to it can be anything. The patient may be allergic to dust, the patient can be allergic to anything. There are many particles which the patients can be allergic. Yes, so ಇಲ್ಲಿ ನೋಡ್ರಿ lung normal, so there is constriction. So ಇಷ್ಟು ದೊಡ್ಡ diameter ಇದ್ದು ಇಷ್ಟು ಸಣ್ಣದಾಗೋಯ್ತು. Okay, and also there is ನೋಡ್ರಿ, so if you take a cross section you can see only this much, the diameter is reduced this much and there is presence of mucus. ಇಷ್ಟೊಂದು mucus ತುಂಬಿತ್ತು, so only this much is patent. So ಇಷ್ಟೇ ಅವೈಲೇಬಲ್ ಸ್ಪೇಸ್ ಒಳಗೆ ಏರ್ ಬರೋದು ಹೋಗೋದು ಮಾಡಬೇಕು. there is liquid in the lungs, so you can imagine what is going on. Okay, so this is what is happening in asthma. So ನೀವು ಏನು ಮಾಡಬೇಕು, now you try to guess what are the drugs you are going to use. First and foremost na ಏನು ಹೇಳಿದೆ ಏನಾಗುತ್ತೆ, there is bronchoconstriction. Okay, so bronchoconstriction ಇರೋದ್ರಿಂದ, okay, so there is bronchoconstriction. So what is happening and what strategy you are going to use. So there is bronchoconstriction, so ಏನು ಮಾಡೋಕೆ ನೀವು dilate it. So you are going to use drugs which are bronchodilators. ಹೌದಾ? Yes, what is the main event which is causing this? There is inflammation, there is hyperinflammation. In fact, reduce the inflammation. Okay, you are going to use drugs which are reducing inflammation, anti-inflammatory drugs. Now remember one thing, inflammation andra bari one ಅಥವಾ ಎರಡು mediators ಇರಲ್ಲ. There are hundreds of mediators which are known to cause inflammation. Histamine, leukotrienes, interleukins ಸಿಕ್ಕಾಪಟ್ಟೆ ಇರ್ತಾವ. So you are going to use a drug which will reduce the inflammation by stopping the action of all this. So broad anti-inflammatory action iruanta drugs, again you can easily guess it, that is steroids. Next, antihistaminics. There is presence of leukotriene, so leukotriene antagonist. So leukotriene irutta, common mediators andre leukotriene kodabodu, leukotriene antagonist kodabodu. Histamine irutta, so antihistaminic kodabodu. ಎಲ್ಲ ಇನ್ಫ್ಲಮೇಟರಿ ಮೀಡಿಯೇಟರ್ ಸ್ಟಾಪ್ ಮಾಡೋದು, ಬಹಳಷ್ಟು ಇನ್ಫ್ಲಮೇಟರಿ ಮೀಡಿಯೇಟರ್ ಸ್ಟಾಪ್ ಮಾಡುವಂತ ಎಫೆಕ್ಟ್ ಡ್ರಗ್ ಸ್ಟೆರಾಯ್ಡ್ಸ್. ಸೊ ಇಟ್ ಗೋಯಿಂಗ್ ಟು ಗಿವ್ ಸ್ಟೆರಾಯ್ಡ್ಸ್. ಓಕೆ, ಸೊ ದೀಸ್ ಆರ್ ಅದರ್ ಡ್ರಗ್ಸ್. ವಿಲ್ ಸಿ ಇಟ್ ಈಸ್ ಕ್ರಾನಿಕ್. ಎಸ್, ಬರೀ ಸಿಂಗುಲರ್ ಇವೆಂಟ್ ಅಲ್ಲ ಇದು. ಒಂದ್ಸತಿ ಪೇಷಂಟ್ ಎಕ್ಸ್ಪೋಸ್ ಆದ್ರೆ ಅಷ್ಟೇ ಅಲ್ಲ, ದೇರ್ ಪೇಷಂಟ್ ವಿಲ್ ಬಿ ಹ್ಯಾವಿಂಗ್ ರಿಪೀಟೆಡ್ ಎಪಿಸೋಡ್ಸ್. ಇಟ್ಸ್ ಅ ಕ್ರಾನಿಕ್ ಡಿಸೀಸ್. ಸೊ ಯು ಶುಡ್ ನಾಟ್ ಟಾರ್ಗೆಟ್ ಬರೀ ಒಂದ್ಸತಿ ಅಸ್ತಮಾ ಅಟ್ಯಾಕ್ ಆಯ್ತು ಅದನ್ನ ನೀವು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟು ಪೇಷಂಟ್ ನಾರ್ಮಲ್ ಆದ್ರೆ ದಟ್ ಈಸ್ ನಾಟ್ ದ ಎಂಡ್. ಯು ಶುಡ್ ಮೇಂಟೈನ್ ಸಚ್. ಸೊ ಮೇಂಟೆನೆನ್ಸ್ ಇರಬೇಕು. ಸೊ ಯುವರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಶುಡ್ ಟಾರ್ಗೆಟ್ ಮೇಂಟೆನೆನ್ಸ್. ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್ ಇಸ್ ದ ಫೋಕಸ್. ಸೊ ಈ ಪ್ರಾಬ್ಲಮ್ ಇರೋದೆಲ್ಲೇ ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್ ಒಳಗೆ ಅಷ್ಟೇ. ಯು ನೀಡ್ ನಾಟ್ ಟಾರ್ಗೆಟ್ ಹೋಲ್ ಬಾಡಿ. ನೀವು ಇಡೀ ಬಾಡಿ ಇನ್ಫ್ಲಮೇಷನ್ ರೆಡ್ಯೂಸ್ ಮಾಡಬಾರ್ದು. ಸೊ ಇನ್ಫ್ಲಮೇಟರಿ ಸೆಲ್ ಲಂಗ್ಸ್ ಅಷ್ಟೇ ಇರೋದ್ರಿಂದ ಯು ಶುಡ್ ಟಾರ್ಗೆಟ್ ಓನ್ಲಿ ಲಂಗ್ಸ್. ಸೊ ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್ ಅಷ್ಟೇ ಟಾರ್ಗೆಟ್ ಮಾಡ್ಬೇಕು ನೀವು. So ಬೇರೆ ಕಡೆ ನೀವೆಲ್ಲ ಕೊಟ್ರೆ it will cause, there is no use and they will cause adverse effects in the body. So why is this, why I am saying this point is, in asthma we use what is known as drugs which are directly given into the respiratory system. ನೀವು ಸ್ಪೆಸಿಫಿಕ್ಲಿ ಕಾಮನ್ಲಿ ಯೂಸ್ ಮಾಡೋ ಟರ್ಮ್ ಏನು, ಇನ್ಹೇಲರ್ಸ್ ಅಂತ ಯೂಸ್ ಮಾಡ್ತೀವಿ. they are known as meter dose inhalers. Okay, so meter dose inhalers use ಮಾಡ್ತೀವಿ ನಾವು bronchial asthma and inhalational group of drugs play very important role in the treatment of bronchial asthma. Why we are using them is simple. So inhalational route of drug administration anta kelbodu. So what are the advantages? They are used in conditions where the pathophysiological changes are seen only in the lungs. So we are going to target specifically there. First thing. Second thing is they will provide immediate effect, immediate action produce ಮಾಡ್ತಾವೆ. That is one thing. I mean, they produce very less systemic adverse effect. So that is one thing. So that's why we are going to use them. Adverse effect andra, there is very less chances of them entering into systemic circulation and cause adverse effect. So that is one adverse effect. One limiting factor or disadvantage andra, the patient should be properly counseled regarding the use of this. Okay. According to some studies, nearly 40% of patients are using this in a wrong way. So that is one limiting factor where you have to educate the patient. And other adverse effect is it can cause irritation to the patient, respiratory irritation. They are all very minor adverse effect when you compare to systemic adverse effect. So that is about inhalational route of drug administration. So what are these metered dose inhalers? ಯಾವ್ಯಾವ ಬರ್ತಾವ ಅಂದ್ರೆ one is inhaler, ನೀವು commonly ನೋಡಿರಬಹುದು. There are other known as rotahalers. Okay, there is something known as spacers use ಮಾಡ್ಕೊಡ್ಬೋದು. There is ನಿಮ್ಗೆ ಗೊತ್ತಿರೋ ಹಂಗೆ so all these are different ways by which you can make sure that the drug enters into the respiratory system. Commonly ಕೇಳಿರುವಂತ nebulization, that is one more. So all these are ways by which you can administer drug into the respiratory system. Now I told that very important statistics which says nearly half of the patient use them wrong. So inhaler na yaar patient kotre, if they are not using it properly, the drug will stay in the mouth instead of respiratory system. So it is causing adverse effect in the mouth and it's not reaching the lung. It is not reaching and the condition starts worsening. So that's why it is very important for you to educate the patient how to use these meter dose inhaler. So these are some steps. So first thing, patient, you should advise the patient to wash their hand. So either you should advise this not only your patient, if you see anyone using it wrong, if you have to go them and advise them regarding their proper use. So wash your hand, close it properly, open the mouth and sit or stand, ask the patient to sit or stand, ಸ್ವಲ್ಪ tilt ಮಾಡಬೇಕು. And next there is something known as hand and inhalational coordination. Okay, hand respiratory coordination ಇರಬೇಕು. So first the patient should breathe out. Next, insert this in between upper and lower teeth. One common mistake is they will insert that between the lips and close the teeth. So ನೀವು ಸ್ಪ್ರೇ ಮಾಡಿದ್ರೆ ಬಾಯಿ ಒಳಗೆ ಉಳ್ಕೊಂಡ್ಬಿಡ್ತದೆ. There is no use. You are not administering the drug to oral cavity. They should reach the respiratory system. So stop ಮಾಡಿ. Then when the patient presses, at the same time they should inhale. Okay, ಅದೇ coordination important. So that is one limiting factor. ಆ coordination ಬರೋದನ್ನ you have to teach the patient. Okay, so press ಮಾಡಿದ ತಕ್ಷಣ they should inhale. Patient should hold the breath according to their capacity. So ನೀವು ಕಂಪಲ್ಸರಿಲಿ 20 seconds breath hold ಮಾಡ್ಬೇಕಂತ, that's not the proper way. At least 10 seconds, tell the patient at least 10 seconds you have to hold the breath, or whatever the capacity is. Madi, then have to exhale, and patient should be asked to wash their mouth, gargle, clean and close it. So all this is very important aspect. So in this the particle will be in the container, the particles will be in a very pressurized manner. So ನೀವು deodorant ಹೆಂಗ್ ಯೂಸ್ ಮಾಡ್ತೀರಿ, ಪ್ರೆಸ್ ಮಾಡಿದ ತಕ್ಷಣ ಹೆಂಗ್ ಬರುತ್ತಲ್ಲ ಹಂಗೆ here also when you press, the particles will be discharged in aerosol. This is known as aerosol particles release ಆಗ್ತಾವ. Their diameter will be such that they will enter into the respiratory system. Alveoli ಇದೊಳಗೆ ಹೋಗ್ತಾವ. Alveoli ಇದೊಳಗೆ ಹೋಗಿ they will enter into the pulmonary circulation and they will cause action. Okay, if you are using powder instead of this, they are known as powdered inhaler or rotahalers. That is one. This pressing amele inhalational coordination will be difficult in unconscious patient, in children, in elderly. So in children we use what is known as spacer. So idu opening part idre there is something known as spacer which will connect this part and here the patient will place the mouth, and when you press, it will be dispersed in the spacer. So child can idanna magu idanna amele respire madodu. This is spacer. Okay, severe emergency condition ittu, patient is not able to do all this, we use nebulizer. Steam mukantra ಅಥವಾ pressure mukantra drug ಏನಿರುತ್ತಾ, it will come in the form of aerosol and or steam mukantra ಬರೋದ್ರಿಂದ patient, there will be mouthpiece so that the patient can inhale. Okay, so these are the drugs which are used for the treatment of bronchial asthma. So avagಲೇ ನಾನು ಡಿಸ್ಕಸ್ ಮಾಡಿದೆ bronchodilators. So one is sympathomimetic drugs. So lungs ಒಳಗೆ ಯಾವ ರಿಸೆಪ್ಟರ್ ಇರ್ತಾವ? beta 2 receptors. So I have told you, remember there are beta 1, beta 2. So you have one heart, so beta 1 receptors are present in heart. You have two lungs, so beta 2 receptors are present in lungs. So beta 2 receptors function, if you stimulate beta 2 receptors, they will dilate the bronchus, they will cause bronchodilation. Okay, so bronchodilation cause ಮಾಡ್ತಾವ salbutamol, bambuterol, salmeterol, terbutaline. So ಇದ್ರ ಬಗ್ಗೆ ನೀವು ನೆನಪಿಟ್ಕೊಳ್ಳೇಬೇಕು in treatment of asthma. And steroids, very important group. Two group of drugs are inhalational steroids and inhalational bronchodilators like sympathomimetic drugs, anticholinergic inhalational drugs like ipratropium, tiotropium bromide, xanthines, aminophylline and theophylline, leukotriene inhibitors or antagonists like montelukast, they'll end with Lucast, montelukast, zipirlukast, master stabilizers, and newer group of drugs like anti-IgE antibody. Okay, so these are the drugs which are used. Now I'll discuss what are the most important drugs which are used. So before going to that, there is one more question they will ask you in respiratory system, that is, what are the drugs which are used in the treatment of cough? So alle try to remember these drugs. Okay, so we'll discuss about this briefly. Okay, so now discuss ಮಾಡಿದಂಗೆ cough is one defensive mechanism. So ಏನೇ ಅದ್ರೊಳಗೆ ಪಾರ್ಟಿಕಲ್ಸ್ ಹೋಗಿದ್ರೆ, ಅನ್ವಾಂಟೆಡ್ ಪಾರ್ಟಿಕಲ್ಸ್ ಹೋದ್ರೆ, ಏನಾದ್ರು ಇನ್ಫೆಕ್ಟಿವ್ ಮಟೀರಿಯಲ್ ಇದ್ರೆ ಅಥವಾ ಡಸ್ಟ್ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ಹಂಗೆ ಏನಾದ್ರು ಹೋದ್ರೆ, ಬಾಡಿ ವಿಲ್ ಟ್ರೈ ಟು expel it out. So we use mucokinetic, or if there is any accumulation of mucus secondary to inflammation, that mucus should be expelled out. Okay, so there is one, that is cough center. So cough center in the cough reflex start agutte. Okay, so see here, pharyngeal demulcents, pharyngeal irritation idra adanna calm down ಮಾಡ್ತಾವ. Okay, many chewable tablets use lozenges, adu. There are expectorants ಅಂದ್ರೆ which will increase you coughing out the sputum ಆಗಿದ್ದನ್ನ ಹೊರಗ expel ಮಾಡುತ್ತಾ. So that is one. There is antitussive or cough center suppressant. Now remember this, if there is any secretion or if there is accumulation of mucus, ನೀವು ಆ ಟೈಮ್ ಒಳಗ ಕಫ್ ಸೆಂಟರ್ ಸಪ್ರೆಸೆಂಟ್ಸ್ ನೀವು ಯೂಸ್ ಮಾಡಿದ್ರೆ ಕಫ್ ರಿಫ್ಲೆಕ್ಸ್ ಜನರೇಟ್ ಆಗಲ್ಲ, ಆ ಮ್ಯೂಕಸ್ ಅಲ್ಲೇ ಉಳ್ಕೊಂಡ್ಬಿಡುತ್ತೆ. ದಟ್ ಈಸ್ ನಾಟ್ ದ ವೇ ಆಫ್ ಟ್ರೀಟಿಂಗ್. ಇಫ್ ದೆರ್ ಇಸ್, ದಟ್ಸ್ ವೈ ವಿ ಡಿವೈಡ್ ದ ಕಫ್ ಇಂಟು ಪ್ರೊಡಕ್ಟಿವ್ ಅಂಡ್ ನಾಟ್ ಪ್ರೊಡಕ್ಟಿವ್ ಕಫ್. ಸೊ ಸ್ಪೂಟಮ್ ಇತ್ತು ಅಥವಾ ಏನಾದ್ರು ಸಿಕ್ರಿಷನ್ ಇದ್ರೆ ಯು ಶುಡ್ ಯೂಸ್ ಎಕ್ಸ್ಪೆಕ್ಟೋರೆಂಟ್ಸ್ ಲೈಕ್ ಪೊಟ್ಯಾಷಿಯಂ ಸಿಟ್ರೇಟ್, ಪೊಟ್ಯಾಷಿಯಂ ಅಯೋಡೈಡ್, ಆಮೇಲೆ ಬ್ರೋಮ್ಹೆಕ್ಸಿನ್, ಆಂಬ್ರಾಕ್ಸಾಲ್. ಸೊ ಇವೆಲ್ಲ ನೀವು ಕಫ್ ಸಿರಪ್ ತಿರುಗಿಸ್ ನೋಡಿದ್ರೆ ದೇ ಆರ್ ಆಲ್ ವೆರಿ ಕಾಮನ್ಲಿ ಯೂಸ್ ingredients. Antitussives andra again opioids like codeine, dextromethorphan, very commonly used, and antihistaminics. So secondary to inflammation idra you are going to use this. If there is bronchoconstriction like we are discussing in asthma, avaga you are going to use bronchodilators like salbutamol, terbutaline. So nim question en ketara, mention 4 drugs or 6 drugs used in the treatment of cough ant kedra, you can write this. Okay, now we'll come back to sympathomimetic drugs. They are known as SABA or selective beta 2 agonist drugs. Okay, so beta 2 agonists are most effective and fastest acting bronchodilators. Remember this point, they are fastest acting drugs in bronchodilation. Sudden, what is the main symptom which is causing this clinical manifestation? Bronchoconstriction. So these drugs will cause fast bronchodilation. What is the mechanism of action? Beta 2 receptor stimulate agutta, increase CAMP, bronchial muscle relaxation. So bronchial muscle relaxation agutta. So this is that molecular level. Increase CAMP in the mast cell and other inflammatory cells are also decreased. So this is main. There is one more mechanism of action, that is this. So what are the adverse effects? They should be cautiously used in hypertension. Why? They are beta 2 agonistic or sympathomimetic drugs. very less, if it is taken by inhalational route, very less enters into the systemic circulation. But in these patients, it may cause activation of sympathetic system. So hypertensives or ischemic heart disease, you should not use them. This is one general adverse effect of this group. So we'll see drugs. What are the drugs in this? Salbutamol or albuterol, terbutaline, salmeterol or formoterol. So these are drugs. Most commonly used is highly selective beta 2 agonist, that is salbutamol. Used by inhalational, produces bronchodilation within 5 minutes. Action lasts for 2 to 4. So acute attack of asthma, you're going to use them. Used to abort and terminate attack of asthma. Okay. Not suitable for prophylaxis. So prophylaxis andreno, if you're trying to prevent this attack, in maintenance therapy, it is not specific drug. Adverse reaction, yes, muscle tremors, kai nadugodu, palpitation, heart rate increase, if you feel the heart rate, restlessness, nervousness, throat irritation and ankle edema. Very specific adverse effect along with hypokalemia. Okay, so this you have to remember. These are about beta agonist. Yavag now system, so what I told was you are going to use inhalational drugs, but where you want to use systemic drugs, there is the indication where you are going to use oral salbutamol when in very severe condition. If it is not controlled by this, along with inhalation you are going to supplement, but now it is rarely used. Rarely there is we use this. If there is failure of this, we go for other group of drugs. But oral bioavailability is only 50%, acts for 4 to 6, but it is causing lots of adverse effects. So the adverse effect will become more prominent. So salmeterol is first long acting selective beta 2 agonist. So ivella jaldi start aitu, duration action was 4 to 5 hours, whereas salmeterol is long acting. So inhaled salbutamol and terbutaline are currently the most popular drugs for quick reversal of bronchospasm. Yes, but what happens? So idನ್ನ ಯೂಸ್ ಮಾಡಬಹುದು. ಎದಕ್ಕಂದ್ರೆ there is diminished responsiveness after long term of use. ಬಹಳ ಹೊತ್ತು ಯೂಸ್ ಮಾಡಿದ್ರೆ ರೆಸ್ಪಾನ್ಸ್ ಕಡಿಮೆ ಆಗುತ್ತಾ. Does not reduce bronchial hyperactivity. So it is not, again I talked about. So we know about cause and effect. Please remember this concept. What is the cause? Cause ಏನಾಗುತ್ತಲ್ಲ? There is hyperinflammation. What is the effect? Effect is bronchoconstriction, accumulation of mucus and everything. So ನೀವು beta agonist ಕೊಟ್ರೆ ಏನಾಗುತ್ತೆ? You are just treating the cause. Effect. Cause there is excessive inflammation. So you are not targeting this. So for that we are going to treat the cause, that is inflammation. So that's why very specific drugs here are corticosteroids. Okay. There is down regulation of beta 2 receptors. How these drugs act? They will act on beta 2 receptors over a period of time. These beta 2 receptors become less responsive, or down regulation of these receptors takes place. So should be treated with inhaled steroid, with or without inhaled long acting beta agonist. So this is the standard protocol. So single usually beta agonist single drug ಕೊಡೋದು in acute cases or mild episodes ಕೊಡಬಹುದು, but when it gradually progresses, it is not at all advised to give only beta agonist. You should always add steroid to it. Next is methylxanthines. So theophylline and aminophylline are two drugs. There are 3 mechanisms of action. So these two are concerned with bronchial asthma. So they release calcium from sarcoplasmic reticulum in skeletal muscle and cardiac muscle. Okay, but here they inhibit phosphodiesterase. Okay, so idrinda enagutta phosphodiesterase agde irodrinda, there is more phosphodiesterase available, it will cause bronchodilation. Okay, so PD accumulation agodrinda there is bronchodilation. So next there is blockade of adenosine receptors. So adenosine will cause contraction of smooth muscle in bronchus. By inhibiting or blocking adenosine receptors, they are causing bronchodilation. Please remember this, they have very narrow margin of safety. So because of this, their use is very much reduced now. Specifically ಮೊದಲು use it, gradually they are coming down the use of this because of narrow margin of safety. Why? It will have some adverse effect like headache, nervousness, nausea are early symptoms. Children are very much susceptible to this, that is CNS toxicity. Next, gastric pain, rectal inflammation, pain at the site of IM injection. rapidly IV injection kotre, there is pericardial pain and syncope, sudden hypotension. Patient may go into sudden hypotension. So because of all this, usually not preferred, but where we want to use in bronchial asthma and COPD, theophylline may benefit by causing bronchodilation. We use this in status asthmaticus or in uncontrolled bronchospasm we are going to use. But in apnea of premature infant, theophylline reduces frequency. So premature infant apnea, difficulty in breathing, these are very, very effective. Yes, anticholinergic drugs, they will cause bronchodilation by blocking M3 receptors which are present in the lung, act primarily on the larger airway, very important, larger airway dilate ಮಾಡುತ್ತಾ. Remember this, bronchodilation, selective beta agonists, they will cause dilation of small airways. So new anticholinergic plus beta agonist kotra, they will open both larger as well as smaller airways. So they have synergistic action. Combination with beta 2 agonist has synergy. Okay, ipratropium and tiotropium, good. They are very specific, more than asthma. They are very much useful in case of COPD. Okay, tiotropium drug use marti now. Next is leukotrienes. So leukotriene is one of the common mediators which is involved in asthma. So leukotriene antagonist use marti, montelukast amele zikirlukast, they will block the receptor cis LT1. So e receptor block ಮಾಡುತ್ತಾ. Leukotriene ಏನು cause ಮಾಡುತ್ತಂದ್ರೆ it mediates bronchoconstriction, airway mucus secretion and increased vascular permeability cause ಮಾಡುತ್ತಾ. By blocking cis LT1 receptor, it is preventing all this. Okay, next, it causes bronchodilation, reduces sputum, ಆಮೇಲೆ ಎಲ್ಲ inflammation reduce ಮಾಡೋದ್ರಿಂದ they have become very important additive drugs. So inhalational drugs ಜೊತೆಗೆ additive ಕೊಡಬಹುದು, not single. Monotherapy kotre, they are not effective. They can be added with other inhalational group of drugs. Okay, adverse effects, they are usually well tolerated. Some adverse effects like pain abdomen, headache, rashes are very commonly seen. Yes, very important, corticosteroids. So we know that steroids inhibit nearly all the inflammatory mediators. They inhibit inflammatory cytokine production and eosinophil lymphocyte. ಎಲ್ಲ inflammatory mediators na interleukin, TNF alpha, platelet activating factor, prostaglandins, ಇವೆಲ್ಲನೂ reduce ಮಾಡಿ. So they will reduce the hyperactivity in the lung, they will reduce the bronchial hyperactivity, they will reduce the mucosal edema and suppress the inflammatory response to antigen antibody reaction. ಅದನ್ನ ಸ್ಟಾಪ್ ಮಾಡೋದ್ರಿಂದ it will reduce the hyperinflammation. So that's why they are these specific drugs for the treatment of bronchial asthma. So beclomethasone, budesonide, fluticasone, and ಇವೆಲ್ಲ ನೀವು ನೋಡಿರಬಹುದು. Inhalation ಏನು ಯೂಸ್ ಮಾಡ್ತಿದ್ರೊಳಗ they are very, very commonly used drugs. Please remember, they are not causing bronchodilation. Bronchodilation cause ಮಾಡಲ್ಲ, they will reduce the inflammation. Bronchodilation ಮಾಡೋದು ಯಾವುದು? Beta agonist, anticholinergic drug. They are not causing bronchodilation, they will reduce the cause. Okay, what is the cause? Cause is hyperinflammation, they will target that. So complete and sustained symptomatic improvement. So they are used in the maintenance. So sudden attack adra, you have to use fastest acting drug, that is beta agonist. Okay, so complete and sustained symptomatic improvement in the airflow is reduced. Ella in changes agirutte lungs secondary to inflammation is reduced by using corticosteroid. Increased airway smooth muscle responsiveness to beta agonist. One more added advantage when you use corticosteroid plus beta agonist andre ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ, ಡೌನ್ ರೆಗ್ಯುಲೇಷನ್ ಆಫ್ ಬೀಟಾ ರಿಸೆಪ್ಟರ್ಸ್ ಆಗಿರುತ್ತೆ. ಸೊ ದೇ ವಿಲ್ ಇನ್ಕ್ರೀಸ್ ದ ರೆಸ್ಪಾನ್ಸಿವ್ನೆಸ್ ಆಫ್ ದೀಸ್ ಡ್ರಗ್ಸ್. ಸೊ ಲಾಂಗ್ ಟರ್ಮ್ ಸಿಸ್ಟಮಿಕ್ ಸ್ಟೆರಾಯ್ಡ್ ಥೆರಪಿ ಅಡ್ವರ್ಸ್ ಎಫೆಕ್ಟ್ಸ್ ನಾವು ಸ್ಟಡಿ ಮಾಡಿವಾಗಲೇ ಇನ್ ಕಾರ್ಟಿಕೋಸ್ಟೆರಾಯ್ಡ್ ಚಾಪ್ಟರ್. ಸೊ ಆಲ್ ದಿಸ್ ಇಸ್ ಸೀನ್ if it is used for very chronic duration. And please remember, if you are using by inhalational route, systemic adverse effects are very, very less, bada kadime irutte. But again, it can cause in some patient. But one common andre inhale ಮಾಡಿದ ತಕ್ಷಣ patient should wash their mouth, because one very common adverse effect is candidiasis, oral candidiasis cause ಮಾಡುತ್ತೆ. So because of that, to avoid that, the patient should wash the mouth and gargle very, very use ಮಾಡಿದ ನಂತರ they have to wash them out. Very important step. Peak effect is seen after 4 to 7 days. So this is because of this, it cannot be used in emergency condition. Okay, it is used in maintenance. Okay, so adverse effects andre So systemic adverse effect kinta local adverse effects very common. I discussed about oropharyngeal candidiasis, that is fungal infection, hoarseness of voice, dysphonia, sore throat. So local accumulation agodrinda. So this can be prevented by using spacer or gargling. Okay. So so how to prevent this? Oral candidiasis can be prevented as well as treated by nystatin. You can use this. Systemic effects of long-term steroids is seen only when you're using more than 600 microgram per day. Okay, it's very less. So very less chances of causing that. Next, we come to one more important emergency condition, that is status asthmaticus. If it is not relieved after half an hour, asthmatic attack, or if there is repeated frequent attacks within very short duration of time, then you can tell the patient is having status asthmaticus or refractory asthma. So ನಿಮ್ಮ question ಏನು ಬರುತ್ತೆ ಅಂದ್ರೆ, what are the drugs used in the treatment of status asthmaticus? And remember, most common precipitating factor for this is usually upper respiratory tract infection. If the patient is having asthma, there is secondary upper respiratory tract infection, then the patient has chances of going into status asthmaticus. What are the drug of choice? Yes, hydrocortisone 100 mg IV stat followed by 100 to 200 mg every 4 to 8 hourly is the first drug which should be given. Next inhalational drug is nebulization with salbutamol and ipratropium bromide, intermittent inhalational with oxygen supply, very important. Oxygen henga high flow humidified oxygen. So idin kodbeku. Some of them use xanthines. Okay, so that is one more drug which can be used. So what are the drugs used under? Humidified high flow oxygen, nebulized salbutamol, ipratropium bromide, hydrocortisone hemisuccinate by IV route. Other drugs which are usually followed are salbutamol or terbutaline 0.5 mg IM or subcutaneous. If it is not controlled, then you're going to intubate the patient and ಮೆಕ್ಯಾನಿಕಲ್ ರೆಸ್ಪಿರೇಷನ್ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬೋದು, ಟ್ರಂಗ್. ಸೊ ಅದನ್ನೆಲ್ಲ ಮಾಡಿದ್ಮೇಲೆ ನೆಕ್ಸ್ಟ್ ಯು ಕ್ಯಾನ್ ಗಿವ್ xanthines ಆಲ್ಸೋ, ಮಿಥೈಲ್ xanthines. ಓಕೆ, ಸೊ ಅಮೈನೋಫೈಲಿನ್ ಕೊಡ್ಬೋದು. ನೆಕ್ಸ್ಟ್, treat the cause. What is the cause? Cause is, if it is secondary to any infection, treat chest infection which is causing this by giving antibiotics. If there is dehydration, which is usually commonly seen, treat dehydration. And respiratory acidosis, treat that with help of IV fluids like normal saline and sodium bicarbonate. So these are all the group of drugs which are used in the treatment of status asthmaticus. So this is about bronchial asthma. So as I said, try to understand the concept first and gradually you can understand the drugs which are used.